Okay. I don't. You want. Right. So case control studies are first and foremost about cases, and to understand a case control study, you have to understand what a case is. And a case is basically an individual in a study with the outcome that you're interested in, and the characteristics that are associated with that person. And before doing any studies, you will see in the literature, and I'm sure you will have done, case series, case reports. These are not really studies, they're descriptions of cases, and they're important in their own rights. You know, when you see a new problem, when you see clusters of patients, and if you go back in the literature, you will see, for example, the first evidence of the HIV pandemic is a case report from 5 patients in California. And then, but then if you really want to go to then understand what factors are, what exposure are associated with the outcome that you're interested in. So you could do a case report or a case series on males with a new infection, but if you want to understand why they got infected, what specific factors, then you need to do a particular an analytical study, and case controls is one of these. So a case report is a single case. Case series is a series of cases. And a case control study is a study design that tries to link the outcome. So the outcome is either a person has a disease or a person has whatever outcome you're interested in, and then another person or another group hasn't got that, and then you go back in time and you look what they were exposed. So what they were exposed. So the key thing to remember about a case control study is that you start with the outcome. You start with the end. You know, patient had this outcome. Patient had a heart attack. Patient had a surgical complication. Patient had rapid progression to the next stage of cancer. And then the other group, you have patients that did not have that. And then you start with these. You start with the end, and then you go and find out what they were exposed to, and then you split them in each of the groups, each of the cases between exposed and not exposed, and in the control between exposed and not exposed. And then you do a calculation, which we'll go through, to find out whether the exposure that you're interested in is associated with the outcome. Yeah. And this is an observational design. You don't do anything to your patients. You don't give them you just look at what happened. That's why it's called an observational study design. And we do this for several reasons. You cannot always, you will hear many times that randomized controlled trials is the gold standard of research. But there are many cases where you cannot do randomized controlled trials because the exposure already happened, because it's not ethical to randomize. You can't, for example, if you want to investigate the association between smoking and cancer, you can't make people smoke to see if they're going to have cancer. Sometimes the exposure is a characteristic of the person, his age, his ethnicity, his gender. It's not something you can expose people to. So you need different designs. The other thing is some diseases are very rare. So you cannot, or some outcomes are very rare. And if you go through a prospective, either a cohort study or a randomized controlled trial, you will not see enough of the outcome to really tell whether there's an association. But if you do a case control study, if you're studying a disease that is extremely rare, say there are, I don't know, 30 or 40 cases in the entire country or the world even. If you start with the disease, you can take all these patients and then look at their exposure. But if you take a random group and wait for this outcome to emerge, you're not going to have a lot of these events. Yeah. So
this will be the cases.
Correct.
What will be the control?
We'll come to that. So let's go through an example. It's not a real life example. We want to investigate whether using hairspray, which is full of chemicals, is associated with congenital malformations. So we start with 100 mothers, and congenital malformations are relatively rare. If you take 100 people who use hairspray, you're not going to have a lot of people with congenital malformations. But you can start with 100 mothers who gave birth to babies with congenital malformations, and then you ask them, did you use hairspray during pregnancy? Okay, and you find that 70% of them had used hairspray during their pregnancy. That in itself doesn't tell you anything. It doesn't tell you whether hairspray is associated with the outcome that you're interested in. But it's the start of building a case control study, because what you do next is you take a comparison group of people who are basically the same, except that they did not develop the outcome of interest. So in this example, what would be a
Kids
comparison?
the same age, mothers to kids the same age, the same ethnicity, gender, blah, 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 that live in the same area, because that can affect you, that have the same diet, that live the same lifestyle, except off hairspray, if you can do that.
Exactly.
Because there are other factors. Maybe women that use hairspray, maybe they also don't eat well. So you have to see if there are not, if there are other differences.
The genetical cause can be the principal cause of.
Exactly.
So
So
we
you
must
wanna
take
have-
information about they have another patient in this family that have the same thing.
I think they should be excluded from the study.
From the beginning.
In the
you
beginning,
must
the
be
100
excluded.
mothers, they should be mothers that don't have other kids with that, or
You must take
So-
all the cause can play a principal effect.
right.
So you're all a little bit ahead of the game, but also, so the bottom line is you want a group that is, so if your case group is 100 mothers who gave birth to babies with congenital defects, and you're interested in congenital defects, your control group is going to be 100 mothers or a certain number of mothers who gave birth to baby without congenital defects. Now, you raised different issues that they may be different in other ways, and this is an observational trial. You get what you get. You cannot choose. It's not like a randomized control trial. You cannot choose the characteristics of your patients who had.
You can decide to take them from the same area. of
You
living.
can. So what you do is, in the way you design it, you try and minimize. What you're talking about is confounding, essentially, other factors that could explain the difference. So what you don't want to do is, for example, take 100 people from with congenital defects from a very small community that, say, Samaritans in Nablus, for example. They only marry. There's like 800 people. They only marry each other. The rate of congenital. So this is gonna, and then if you do that, and then take a control group that is a much more. Exactly. So that's not going to work. But what is important is to try to understand what the confounding factors might be, and then you can control. You can't necessarily choose on, because you mentioned a lot: socioeconomic status, genetics, exposure to
And
other
lifestyle
chemicals,
can be
etc.
connected.
Lifestyle.
Maybe women that use hairspray, they have other things they're
Yeah.
doing.
So you can adjust for that. You need to find out about as many characteristics as you can and adjust for that. But what you should try to do when you recruit is that the two groups are as similar as possible. And this is choosing the controls is probably the hardest thing in case control studies, and the element of the design that is most likely to introduce bias in your study. Right? So you've done that. You've got your cases and you have your controls. So your cases have the outcome of interest. Your controls don't have the outcome of interest. and then you look back at the exposure. Okay, so this is exactly what you suggested. We have 100 mothers with babies with congenital malformations, 100 without, and we select them now, and we ask them about the use of hairspray in the past. In a case control study, you cannot measure the amount of disease in a group. You cannot calculate incidence, and you cannot calculate prevalence, because incidence and prevalence depends on the size of your population. Say for example, you recruit 100 cases and 200 controls. Yeah, you have 300 people.
You cannot say
You cannot say 1 in 3 children are born with, yeah? So you cannot use the standard ways that we have to measure disease. You cannot use incidence, you cannot use prevalence. And you cannot use risk, because the risk is based on the size of the population. So that's why you will see when you do case control studies and when you read case control studies, you will see people use odds and odds ratios rather than risk and risk ratios. And we'll try to, I don't want to go into the math too deeply, but the odds is the number of people who have an outcome divided not by the total population, but by the number of people who don't have the outcome. So, you know, if I'm looking in this room, there's 5 of you, the risk of someone having a pink shirt is 1 in 5, yeah? But the odds of someone having a pink shirt is 1 in 4. The people who have it divided by the people who don't. And in case control studies, that is the only thing that we can calculate. We calculate the odds that the cases and the controls are exposed to whatever exposure you're interested in. And then you compare the odds of exposure in cases versus controls. And that's why it's called odds ratio, because you're doing the ratio
it's the odds, so it's not the odds of having the disease.
No, it's the odds of being
exposure.
exposed. Absolutely, exactly. Okay, so you have your cases and your controls, and what you're evaluating is not whether or not they have the disease, because we already know that, but it's whether or not they were exposed to the exposure of interest. So what you're studying in a case control study is the distribution of exposure in cases and in controls. And the only thing you can measure about the exposure is the odds of exposure. Does that make sense? It's not easy.
Yes.
That makes sense. Does it, will it prove that hairspray cause the defect?
No.
No,
No,
you cannot
not
say
right.
that.
This is, okay.
So this
That's
is
a causal finding. There are tons of papers showing
absolutely.
causality between things that have nothing
Well,
to do with
לא, למה? נתקלת את זה.
it's a very important question, and let me answer this very simply. There is no test in the world, there is no study design in the world that can prove causality. You can prove associations. You can prove that one factor is associated with another factor, but proving that one factor causes another factor this is where interpreting the data comes into play. And we'll have to talk about causality, but not right now. What we're trying to do in any study is to show an association. And then you need to exclude other factors. You need to exclude bias, you need to exclude confounding, you need to exclude chance,
You need to have pathophysiological.
and you need to have certain
Logic.
criteria to show that. So, you know, you can show, for example, that the incidence of tuberculosis in the United States is very strongly associated with the importation of Japanese scar, because they happen at the same time, and the correlation is very strong. Of course, it doesn't mean that necessarily importing Japanese scars decreases the incidence of tuberculosis.
Is it a number of association that will be valid? Let's say the association is for a pink shirt is 25%. So is 25 means an association, or it needs to be 75?
No, so it's the strength of the association, how strong is the association, is one of the many factors that makes you believe that it's more likely to be a causation. If you have a very, very strong association, it's one of the factors, but in itself, it's not enough. You can have an odds ratio of 25. It doesn't mean that it's causal. The numbers tell you nothing about causation. They just tell you about the strength of the association. Right. So when we select the cases, selecting the cases is relatively easy, but you need to be very strict about having a case definition. And we saw a little bit in the beginning how you define cases. You have, criteria in time, in place, in person. And, you need to stick to these. And identifying the cases generally is quite easy. You know what you want. Children who attend the emergency department with injury X, Y, and Z. Patients with stage 3 cervical cancer on such and such treatment. Blood samples from such and such departments received between X and Y. So you can define these quite easily if you stick to the time, place, and person criteria and go through the process that we went through in the previous lectures. You'll be able to define your cases. And as I said, you have to have a standard case definition. You need to decide before who is going to be in and who is going to be out. And this is why the protocol, and stay with it. And that the temptation is, when you write your protocol, you have inclusion and exclusion criteria. And it's very easy to be tempted to stray from this. You do your study and you realize I only have 12 patients who fit these criteria, and I want a little bit more. So I'm going to this one is doesn't quite fit, but I'm going to include it.
We're doing a research now about the coronavirus intentions of parents in the ED. And I said, maybe we can go to the ward because the kids that are in the wards went through the ER, but we decided not to include it because it's another population.
So you have to think very carefully whether
to stay with
you have to stick. This is one of the key things in research, and one of the things that people do most commonly is you start with something and you change it. And if you want to be a purist about it, you should really stick to your plan, because in your plan you've thought about how to eliminate bias. And if you change it, then you will reintroduce bias and your result will not be as reliable. And for example, you also you need to, so say for example you want you want to do a study on hepatocellular carcinoma. Well, you need to decide whether, for example, do you need pathological evidence, or are you going to rely on clinical suspicion? Well, that's going to change your study. It doesn't really matter which one it is. You can justify it, but once you decide, you stick to that. So if you go with a pathology report at a later stage, you're not going to include people without that evidence just because it suits the needs of your study. Or if you do, you need to think very, very carefully about what the consequences are and discuss it with someone who has experience in study design. Now, the cases is the easy bit. The controls is the hard part, because the controls should basically, they should not have the outcome of interest. But other than that, they should basically be people who would have been cases if they had the outcome of interest. So they should essentially fit the same criteria, except for the outcome of interest. So when you define your cases, if you have definitions around time, place, and person, a certain age, a certain area, a certain, attending a particular service, your controls should match that as closely as possible. The only difference being they don't have the outcome of interest. So if you're doing if you're doing a study on hospitalized patients, you cannot use controls from the community, for example, because people who attend hospitals are different. They're poorer, they're older, they have more comorbidities, etc., etc. It doesn't mean that they have to be exactly the same.
It's a population, they're different.
But you should try. It only matters if the characteristics make a difference. Like you cannot match exactly. If you have 20 patients you're not going to find 20 patients who are exactly the same age and exactly the same socioeconomic level, etc. But you should, at the population level, you should ensure that they come from the same they come from the same source population. And the small differences, you need to measure them and you need to adjust them in the study. And this is really the hardest part.
Okay, I have a question
Yes.
here. In my case, in my study, I have the control arm, the same patient, but from the healthy tissue from the blood.
So
That's mean that I will compare the bladder tumor to the healthy
Yeah.
tissue from the same patient. So,
no, it's absolutely fine. So when we say patients, maybe I shouldn't use the same patient because your cases and your controls are not necessarily people. In your case, it's
because
It's
it's very
tissue.
difficult to take
yes.
someone healthy to do a surgical intervention for nothing for him.
Yeah. So there's in case control studies you can do self-controlled studies where the controls are the same patients, but either in your case a different bit of the patient. In some cases it could be the same person before, for example. So your controls are a period of time in the past.
That's in
In
my
your
research.
cases, yeah, exactly.
What they did in Tipat Halav and what we find now. So is there
And
difference between-
there's a lot of advantages to that because everything else is similar apart from the fact that the outcome that you're interested in is whether the tissue is has cancer or not. So your outcome is cancer, not cancer. Everything else is the same because it's the same patient. The genetics are the same. Whatever the patient was exposed is the same, etc., etc. In Hannah's case, the patients are samples. They're not people. They're a part of the person. So it's not necessarily people, but you have to think whether if it's samples, whether they match. It's the same principle. The outcome is different, but the rest is the same. So if it's blood samples, they have to come from the same population. In your case, they come from the same patients. So you actually matching each case with itself as a control.
Sorry about that. Was it stronger if he could take patients going through other surgeries, not because of cancer, take healthy tissue from healthy patients without cancer?
But it's very difficult because when I'm going to explain for the patient the operation that
No, I mean
he will
patients
go,
going through operation for other reasons,
the
not
adverse
cancer.
effect, I know, but the adverse effect from the operation that
Yeah.
I'm going to do, that will be acceptable for
No,
So-
not a new operation. I mean, if you have a case of doing the same operation for other reasons.
So like people who have
From the
a
same
a bladder biopsy for other
For
reasons.
example, someone going
Yeah.
to
There
do
is a
chemo-
research concerning fasting and sedation. And they took people that went through MRI for other reasons.
Yeah.
Abdominal
I think
MRI,
that would-
and then they looked at the content of the stomach compared to the time of the last meal. They saw there's no, so they took patients going through MRI.
Yeah.
Not for the study, just
I
went for
understand.
MRI.
Yeah,
for other
that would
reasons,
be
And looked at something else.
I think it would
the
be-
MRI that have the abdominal, each pathology have not the same protocol for the MRI. It's very difficult to compare that.
I think you could, I think you could justify taking other patients undergoing the same procedure for different reasons. This is very common, when you do a study on a particular outcome in hospital using patients from a different departments in hospital for very different reasons, it's very common. But as Mohammed says, you also have to be pragmatic. The ethics around this is complex. You certainly cannot take tissue from healthy patients just for the purposes of the studies because there are potential, risks of doing a bladder biopsy. What you have to think about, there isn't like one way to do a study. What you have to do is, are you satisfied that the design is not going to introduce bias between the control because the controls are very different from the cases? It doesn't mean there's only one right answer as to who your controls should be. but it has to be, you have to make sure as much as possible within the constraints that you have, costs, ethics, etc., that they are matching the cases. So yeah, so if you're doing a hospital study and your cases are in hospital, you have to have controls from the hospital. If you're doing a population study in a particular area, your controls should come from the same area as much as possible, because the more different they are, the more likely you are to introduce bias. If you're doing, you know, in some cases, if you're interested in particular aspects where genetics is important, like you were saying, siblings could be good if you want to control for genetic factors at the design stage. So you really need to think about what your particular study is. But the bottom line to remember is your controls should be essentially come from the same source population and be as similar to your cases, except that they didn't develop the outcome of interest. Right. So in the example that we had with our study on congenital defects and hairspray, if all the cases were identified from a maternity in a particular hospital, your control should, you know, ideally come from the same maternity in the same hospital. You don't want to use people from other wards. You don't want to use, say, the intensive care where you're already selecting patients who are more severe. You want to try and standardize the recruitment process. Yeah. Yes.
How do you overcome a finding that out of 100 women in the control group, only 5 used hairspray? You chose them, you did everything okay. You did a great match. Let's say not 1, not 5, 1 out of 100. And in your defects babies group, you had, let's say, 50 mothers.
So if you have very large effects,
Okay.
you have to think. So I'll take that question in a bit, because the next
Okay.
slides are about this.
Okay.
So you may have an idea of what you're doing. You may have a hypothesis. You may think, you know, I don't think that hairspray is associated with congenital defects, because I read papers about it. And then if you find a result that is very different from what you expect, then you have to think, did I do something wrong in the design of my study? Is there something that explains this that I didn't think about, or is it a real result? So you have to exclude. You have to think: is your sample big enough? You know, like for example, if you have 2 cases and 2 controls, it's a very small sample. By chance, you could have 2 in one group and 0 in the other group. But if it's a very big sample, then chance is unlikely. Then you have to think, you know, is there bias? Maybe for some reason or another, they forgot that they use hairspray. I mean, it's unlikely in this case, but you have to exclude other reasons. And then if you excluded everything else, then you have to think, is it plausible? Is it, you know, is what I'm seeing likely to be real? If you have really strong doubts about it, maybe people lied. You know, if you ask people, if you're doing a study on, I don't know, cheating on your wife and husband and HIV, maybe people are not being honest about it. You know, there's all kinds of things. So you have to think.
There's a lot of reporting bias, right?
Yeah, there's reporting bias both from the informant, from the. So
we'll talk about biases next.
We'll talk about bias next week. Correct. The number of controls I don't want to spend too much time on, because that's something that should be discussed with a statistician. But you can choose to have 1 control for each case, 2, 3. Once you start reaching 3 or 4 controls per case, there's no benefit in having more and more and more. It doesn't add to your statistical power. But something that can be discussed, and you can also match the cases and the controls to control for certain factors. This is getting a slightly more complex set of designs, and something that you should discuss with a statistician or an epidemiologist, whether you need to match. So matching means you, for each case with a particular characteristic, you find a control with the same characteristics. So for example, if one of your cases female, you want to control that is female. If each of your case is a smoker, you want to control that is also a smoker, etc.
Sometimes in reality, it's not that easy.
It's not that easy, especially when you're doing, you can try and you can match by age groups. There's pros and cons to matching. Matching is not a magic solution that will completely take confounding away. It can help in some instances. This is something that I suggest you discuss with an epidemiologist or a statistician when you're thinking about your study, because it complicates the analysis a lot as well. It's important that you treat your cases and your controls exactly the same way, that you measure the exposure the same. So, you know, if you're talking about, say, hairspray and congenital defects, if you are convinced for one reason or another that hairspray, you know, causes congenital defects, and you need to ask the questions in the same way. You need to have standardized tool. You can't go to the cases and say, are you really, really, really sure you didn't use hairspray, and not do the same in the controls? Because you will, you know, I'm taking ridiculous examples, but most researchers don't do this on purpose. But all of us have our own biases, we have our own beliefs, and it's very easy to do this. Not because you want to cheat on your study, but because you think that a certain result is more likely, and you will influence the result. That's why having, you know, several people working on a study, having standardized tools, it's really, really important. You cannot have a case control study when in one branch you measure the exposure using you know, medical records, and in the other one you just ask people, for example. It needs to be standardized. So what we're doing in the analysis, as we said, is we start with the outcome, and what we're measuring is the odds of exposure. So you're looking at the odds of being exposed among cases and the odds of being exposed among controls, and then you do the ratio of that, and we'll see this. So if we have 100 women who had babies with congenital defects and 100 without, and the 70% of the cases say I used hairspray, and 70% of the controls said I used hairspray, it's basically the same. There's no association, right? So if you did the ratios, you would have in the cases you would have 70 over 30, yeah. And in the controls, you would have 70 over 30, and then you do the ratio of the two, and it's 1. You divide one number by the same number. But now, if you had 70% of the cases who used hairspray, but only 40% of the controls use hairspray, then you can see that your odds ratio will be more than 1, right? And that suggests an association.
But it also depends on the distribution around that point.
Well, at this point, you're asking in one point in time. You say, you have this outcome. Did you use a hairspray during pregnancy? Yes, no. Of course, you could have more complicated studies where you look at, did you use in the first trimester and the second trimester? In this case, this is not the research question. The research question is, did you use it during pregnancy? I agree that it's not a very informative study. It's not a real study, by the way. It's just an example.
If I do the calculations, you get here 1.5.
Okay, so I didn't do the calculation. So this would mean that women who have babies with congenital malformations are 1.5 times more likely to have used hairspray during pregnancy compared with.
How did you do the calculation?
So the calculation is it will be 70 over 30 divided by 40 over 60.
Okay.
The odds. Yeah.
40 over 60.
Yeah.
So it's the odds here, and it's always the cases against the controls.
We'll look. I think we'll look at the numbers in a minute. We'll go through the actual. We'll go through the example. Okay. So this is the example here. So now we have this is our study, we have 100 cases and 200 controls, right? So, and you can see the 2x2 table. This is a very good way of presenting your data. You have the exposure on the side, used hairspray or did not use hairspray, and then the outcome at the top, had a birth defect, didn't have a birth defect. So this creates 4 categories, right? Exposed with the outcome, exposed without the outcome, not exposed with the outcome, not exposed without the outcome. And you put the numbers and you can do the math. So the odds of exposure here in the cases is 40 divided by 60. And the odds of exposure in the controls, we have 200 controls, 2 controls per case, 80 over 120. You can do the math. The odds ratio is 1.
Right.
Okay, which tells you there's no association. Now, in the second example, we slightly changed the numbers. So now we have 135 cases and 190 controls. And of the 135 cases, 55 were exposed. In the 190 without the outcome, 30 was exposed. So you can do the odds in each group. Odds of exposure in the cases is 55 over 80, which is 0.69. And the odds of exposure in the controls is 30 over 160, 0.19. So if you then do the ratio of the two, the odds of exposure in the cases divided by the odds of exposure in the controls, you'll get 3.6. And what this number means is that mothers whose babies were born with congenital defects are 3.6 times more likely to have used hairspray during pregnancy compared to those who didn't.
It goes from the outcome to the reason,
Correct.
as opposed to looking at all the women using hairspray
Exactly.
and follow them and see how many birth defects are.
Which you could also do. And it would be, in a sense, it's a better study design. It's also much more expensive to do, much longer, because this is very easy, right? You find your women in your maternity and you ask them, if you want to do the other way around, you have to find 100 women who use hairspray and 100 women who don't. Remember, you start with the
Right.
exposure, and you have to follow them through 9 months. So you already have, imagine the time it takes compared to the case control study. So there's less risk of bias, but it's also more complicated and more
But we
expensive.
cannot say here the opposite thing. That means not all the mother that use hairspray, they have a chance 3.6 to have a.
You're absolutely right. So we cannot say, technically, that women who use hairspray are 3.5 times more likely to have congenital birth
That you
defects.
could say in my design.
That you can say with a cohort study, or or sometimes
So
with
if you do the study, as I said, you take 100 women who use hairspray, 100 women who
Yes.
don't, and you follow them.
yes. So that's a
Then
cohort.
you can say,
Correct.
say this woman
Correct.
has 3 times
Ongoing
more
study.
Correct.
possibility.
So if you want to be strict,
That's called cohort.
cohorts, we'll go through it next. If you want to be strict with case control studies, what the results show you is about the odds of exposure.
Right.
Practically, you can think whether it means the same or not. It's not exactly the
I don't
same.
think
It's not exactly the same. So exactly as both Dana and Mohammed you said, what we're comparing here is the exposure between cases and controls, not the outcome between exposed and unexposed. So if your odds ratio is more than 1, if your odds ratio is 1, there's basically no association. If your odds ratio is more than 1, then there's a positive association, meaning that your exposure is more likely in cases. And if your odds ratio is less than 1, your exposure is more likely in controls, which means basically a protective effect.
And sometimes people start with that, and if you see an association, then you go to the cohort study.
Absolutely.
So
So
your point, because it's more
Absolutely. So-
difficult, it's more time to
correct.
retrospective and prospective.
So sometimes if you're really interested in a particular question, but you really don't know, you don't want to You don't want to embark in a very long, complicated, and expensive study with no prior information. So you could do something like this, which is relatively cheap and relatively quick. And as you say, if you find a very positive result, then you can decide, actually, I'm now going to do a cohort study to confirm that. So
sometimes what I see in emergency medicine literature is what they do is after they have a cohort study, let's say in the States.
Yeah.
They say, okay, what would have happened if we use that tool in Israel? And then they do a retrospective study that
Yeah,
if we use that tool in our patient, what would be the result?
Yeah.
So it's like,
yeah, you can
use it on the other
do
way
that as
around
well.
too.
Yeah. The other reason not to do what you suggested, the cohort in this case, is congenital defects are relatively rare. So if you follow 100 women, 200 women, you're actually going to have very, very few congenital defects in the end. Whereas if you start with the congenital defects, you're much better off, you're much more likely
but
to
that's
find
what
an
they do with
association.
drugs.
So you have to think about
When they
the-
approve a drug, that's what they do.
Exactly.
They need many patients.
Yeah, so for example, safety studies in vaccines is a
Right.
good example for very, very rare effects. It's very hard to detect using a cohort study. If a side effect is 1 in a million patients, you cannot do studies that are big enough to detect that. You have to start with the outcome and then look at the exposure. So, there's this whole idea about grading of evidence that randomized controlled trials are the best and then cohort is second best, etc., which is true to some extent, but the exposure and the outcome you're interested in will also determine what is the best design. So if you need quick, cheap studies that may not be enough in themselves, but at least if you started, it's good to think about. If you're looking at something that is really, really rare, case control studies may be your only option. Yeah. If you're looking for a really rare, I don't know, G6P, G6PD is not that rare, but something that is really unusual that would require you looking at millions of samples to find it, then a case control study would be a good place to start, because you get all the samples with that rare outcome, and then you look at the exposure. And you can also look at multiple exposures at the same time.
I have the same population of patients who get the same treatment time after time, okay?
Mhm.
The only exposure that is changing is the number of the cycle. So I have them on cycle 1 with some outcome. I have them on cycle 2 with some. So I can ask the question regarding the whole group and compare cycle 3 to cycle 1, which means different exposures.
Yeah.
Would it be valid?
It would. So what is your outcome in that case? Toxicity?
Toxicity.
Okay.
Any kind of toxicity.
Yeah, so you could say, for example, your outcome is toxicity, like a specific toxicity, say, severe peripheral neuropathy, and your exposure is
Number 1 to
yeah,
10.
one. So you say
Number of cycles.
number of
Number of
cycles,
cycles.
exactly, and you can look at there's an association.
Does it make sense?
Of course, it makes sense.
Bye. I'm doing 100 of this and I'm done.
Right. There are, however, limitations to case control studies. We
Yeah.
talked about the selecting the right controls. So that's selection bias. Recall bias is also one of the major problems in case control studies. Recall bias is when cases and controls don't remember the past in the same way. Let me give you, a classic example would be, say you investigate an outbreak of severe, E. coli infection, where patients had hemolytic uremic syndrome, and it's food related, right? Now, if I ask you, tell me everything that you had for every meal in the last week, you're probably gonna not remember that well, right? If you're in hospital, severely ill, thinking what has caused me to have this, you will remember, your brain will remember it much better. It was the same thing, this was one of the classic things with the MMR and autism thing, okay? If your child has autism, you will look for a reason and you will try and remember everything that happened in your child's life before he developed his diagnosis. So you will remember much more precisely what happened compared to the control group, because there's no reason for you to recall this information. This is recall bias. When cases and controls, remember the past differently. And it's one of the major limitations of case control studies. Sometimes reconstructing timelines retrospectively is not easy. You know, like for example, we're doing a study on long COVID, and we ask people, you know, when did you do your first test, or when did you do when was your first dose of COVID vaccine? Well, people mix up the, you know, was this the test? Was it the vaccine? Was this my first test? So actually recreating timelines and establishing temporality is quite difficult with when you start at the end and then go back in the past. Right, we're going to stop here with case control studies.
Are we gonna have a break now, or which one is next?